Dearman, she's our Associate Dean of Research and Development, and Dr. Henrietta Brown, she works in Adult Health College of Nursing. So just want to recognize that they're not here. Today we want to talk to you about a project that we've been doing. We've just finished our first year of a 3-year grant, and it's for interprofessional collaborative practice to improve patient outcomes. So I will talk to you a little about it. Pretty much our purpose of the project was to facilitate interprofessional collaborative practice innovations through the development of leadership, core competencies, the use of technology, especially among our nurses. It was a nursing grant, so there is a focus on nurses being better leaders. We typically look at that medical hierarchy where the doctors are at the top. We're trying to encourage nurses to have more of an active voice, so that was part of the project. The project addressed 4 goals. We needed to develop faculty expertise in leadership and interprofessional collaborative practice. Anybody who was at the keynote presentations and workshops on Tuesday talking about communication, developing common languages, some of those exercises to improv and have some discussions that probably aren't real uncomfortable or aren't real comfortable to have, that was important to us. Developing a culturally responsive and respective clinical practice curriculum. Cultural competence is a big thing, particularly in the health professions, so making sure that our curriculum was fitting these values was important. Utilizing models geared to improving patient outcomes, and then evaluating our program and disseminating our outcomes. Pretty much this is significant for us because the health model is shifting, and we have more of a focus on interprofessional collaboration in healthcare. Some of the challenges that we have in doing literature reviews and working with MUSC, University of Colorado at Denver, University of Maine, some of the leaders in interprofessional practice, is they're all starting in the education realm. So they haven't really gotten into how do we integrate these core competencies and interprofessional experiences into practice. And Paulina and Raphael, you guys talked a lot about some of the things that we feel like we're going to lead into. Some of those different disciplines saying, well, this is how we do things. You know, and you do it differently, and we have to assess this way and you assess that way, so that was a challenge. It's limited research in acute and community settings, and we're seeing a shift from hospital into the community. And so some of the people who are practicing clinically are doing it in hospital rotations. That's a lot easier than coordinating community sites and how you get multiple health professions in those environments. And then also students focused on learning outcomes. So a lot of the projects are looking at, are our students learning the competencies versus are the interprofessional teams actually making the difference in the patient outcomes versus is it just an individual who's doing that? So we were like, we're going to follow grade after them. We also have some challenges. You know, don't forget health information technology with all the changes with that coming along, and then also the lack of fidelity in methodology and interventions. So when we were doing our matrices, we had the same problem. We didn't find a lot of fits for what was currently being done in education and practice to kind of connect both of them. And so we just need to make sure that we ensure these meaningful experiences because it's one thing to learn it, it's one thing to apply it. So that's really what the point of our project was, to get in clinic and actually apply some of the competencies we were discussing. We used for our framework Rogers' Diffusion of Innovation and Cotter's 8 Steps for Leading Change. You were talking a little bit about some of those issues. Cotter kind of looks at the holistic approach and proposes these 8 steps for making some of that change. So he might be a good model for you to use. We were thinking, yeah, we could help him out. So essentially his 8 steps, we kind of connected with Rogers' Diffusion of Innovation because you do need change agents. It's important that the people who are involved in the project aren't the ones who are tenured faculty, although we do have tenured faculty with us, but who are resistant to change. Because if you start with them, you're not going to get very far in making a change happen. So our first step was developing a sense of urgency, and basically that's why do we need it? You know, you have to create a sense of need, especially with administrators. You know, we've got so few faculty, we have so few resources. Why do we need to give resources to you guys to help do this? Step 2 is creating the guiding coalition, and we put Rogers' change agent. These are the people who are really going to start the movement. Got to make sure you got the right players at the table. Step 3 is developing a vision strategy. So that common language, we definitely have to make sure we're there. So Dr. Whitworth will talk to you a little bit about it. We thought we were all on the same page for a while, and we weren't. So we had to get on the same page by developing a vision that everybody agreed upon and we could move forward. communicating the change, mass media, through different disciplines. You know, you've got to be able to move that information out, and actually we're getting a lot of people now after year one going, we want to be involved in the project, and that's just through word of mouth, through faculty and students. Empowering for action, so we got to remove any barriers we're finding. In year one we found quite a few barriers that we have had help addressing, but some of them also are still barriers. Generating short-term wins, so making sure you're celebrating successes and recognizing people who are doing things that are kind of above and beyond. Our evaluation and tenure promotion isn't really, you know, looking for people who are spending all their time doing some of this stuff. So you've got to recognize them some type of way so that they feel like, you know, they've got some kind of recognition for it. And then never letting up, so keeping the momentum going, and then we really haven't gotten to incorporating a culture of change yet. We're not there. We hope to be there by the end of year 3. And so these are the core competencies and how this core competencies for interprofessional practice, 8 organizations came together from all the health professions and put these together. So we've used it as our basis for all of the medical physician assistant, physical therapy, nursing, all their big professional organizations came together. They identified 4 core competencies. So values and ethics, roles and responsibilities, communication and teams and teamwork. And within each of those 4 competencies, they have some different competencies within each of those. So we've used interprofessional education. This is their definition they use. We kept it consistent with our team in interprofessional collaborative practice. Just wanted to bring those up so we have a common language in the room of what we're talking about when we talk about interprofessional stuff in this project. And I've also given you the resource. You can download this manual as well if you are interested in it. Okay, and I'm going to hand it over to Dr. Whitworth.
Okay, I'm going to give you a little overview of actually what we implemented with our project. We conducted it through August 13th, and then we had our second semester with May 2014. This is a funded grant through HRSA NEPQR grant. We were fortunate to be one of 13 in the United States that was accepted for this grant and awarded it. And I think that the big thing with us is that we were going to actually look at the community setting, and we were not starting with the educational didactic component of teaching students. We were actually going out there and integrating the students, an interdisciplinary student team into the community, and to evaluate an improvement of clinical outcomes of our clients that we serve, which that is the end thing of what we want with this interprofessional collaboration. Our participants, our demographics, we had medical students, we had 6 nursing students, 82, and physician assistants. This is what we wrote in when we sort of did our background, our needs assessment, when we were getting ready to write up this proposal. Those were the 3 main areas of the disciplines that we knew had a very strong drive at our university to really want to start doing this interprofessional collaborative education. 76 females. Fall we had 76, in spring we had 50. The difference there, we received the grant in September and we had to hit the ground rolling, and so we decided to do a pilot project. So our nursing students were all volunteer students in various areas, because we could not change our academic calendar at that time. Then in spring, what we decided as we were refining what we had learned from the fall, that we really wanted to do teamwork. And teamwork, you really want to be together more than one time. So we actually recruited students from the different areas, and they worked as teams. So they were at the clinic site every 3 weeks as a team, as a cohort. So this we really saw that worked really well with our team and teamwork. So in fall, in fall we used 15 Place. 15 Place is a homeless shelter. We realized that as we looked at our needs in our community, there were great many needs of an interprofessional collaborative practice. So we first decided to go to 15 Place, a homeless shelter, where we had, you know, the homeless. We had just had one of the largest mental health institutions close in our area. Those clients that were not placed in group homes or at other institutions, they were deemed safe to live out in the community. You know, we found that a lot of them were now homeless. And then the next semester, this past semester, we went to Cathedral Place. And Cathedral Place is an independent living senior retirement home, if you will. And we had all walks. We had some of those patients that had that were released from this mental institution that were living there. We had low socioeconomics. We had, you know, the very aged. A lot of our clients that we saw had a lot of comorbidities, multiple complications. And so these are the two places that we have really targeted that we want to set up our teams. So we first started with an IPAC orientation, which was online, which the students were to go up and to view and kind of look at those core competencies to see what we were trying to, our goals for this, you know, project that we were going to have. The project included 2 clinical days at each site. That would be Tuesdays and Thursdays. And this, I will talk later on. You're talking about the disciplines and crossing the lines, having an academic setting or schedule already set up, very difficult to change days. So we mutually agreed that we could meet on these 2 days in the afternoons from 12:30 to 5. Instructional materials, which I'll show you how we developed a project site on our university educational system. And we had information online for the course. And then also we provided a place where they could go back and give us some good reflection and some positive feedback, because it's interprofessional collaboration. You have to have a buy-in from all of them. So we wanted the students to feel like they were the ones who were developing. And I was one of the project team members. That was at 15 Place, and now I'm at Cathedral Place. And I really just wanted to let the students know that this is your clinic. We want good patient outcomes, and as healthcare professionals, this is our ultimate goal that we want. How are you going to devise this working as a team? So for the tools, which I'm going to show you, I kind of presented to the students, each one of you in your profession has a different way of assessing. You have a different focus. You have different outcomes that you want. But how can we develop tools that we can use that will encompass all of that? So all of my students got together, all of the teams, and they developed everything that we're using in this at our clinics. We have the first semester, we really went in and utilized we modified an instrument from the medical school, because like I said, we had to hit the ground running. So we took that medical school, we got with our other faculty, our other project team members, and kind of modified that to try to fit, because we had to have something where we could measure what we were doing. And then the second semester, we started having the students from that and from the things that they use in their curriculum that they had been through, these other tools. This is our project site that they can go to, and has the welcome, has all the material, and we also gave them a copy of the core competencies that they could read ahead or go back and refresh on. And then our first semester, and now we have independent reading material that they could go in to read about the population that they were serving, videos and different competencies and cultural competencies, ethical competencies, and medical. And then at the end of their rotation, we had a wiki site set up where they could go back and give us some reflection that we could draw on. From that, then we built on our next semester, and that's how we're doing it each time. Got some very valuable feedback from them and some very good positive feedback from how they're already valuing their interprofessional education that they're receiving, because what we see in the research, and with all the years that I have been a nurse for 25 years, I see that we've got to start with our students rather than starting with the professionals that have already got their practice in place. This is the first form that we just used. We modeled it from the medical assessment sheet that they have for their first-year students.
Can't really see it. And if anybody's interested, we can email you copies.
And then the next one, this is the first one that my students, they modified the Adult Prevention and Chronic Care Flow Sheet. And this was just a way of, how are we going to interview? What are we going to say? What do we need as each discipline? What do we need from there? So they all got together and they did an input of what they would need to continue on with the information and the assessment information that they would need. And then the next one, you really can't see this. What I had my students, I try to start telling them, you know, you're going to go out into the healthcare profession, and your ultimate goal is improved patient outcome. And when we have, we want to make this, you know, we want to drop this patient's blood pressure. How are you going to measure it? They need to start learning in school at this, you know, undergraduate medical schools. This is we use first and second year. How are we going to measure our outcomes? How do we know? Because ultimately, that common goal that they have with nursing, physician assistants, physical therapy, that's ultimately our goal. They've got to start thinking. So I wanted them to devise forms that said, yes, this is a health and wellness clinic, but what are we going to do and how are we going to measure, and what type of instrument are we going to use in order to measure those outcomes? So phase 1, project planning, we did the assessment of our project sites. Like I said, we used 15 Place and Cathedral Place. We had developed the proposed grant to go into the community because that is our greatest need. Like I said, I've been in nursing for 25 years, and our population is in the community, be it you know, children all the way up through the geriatric. And so we really need to start turning to that port. If we want continuity of care and interprofessional disciplinary collaboration, it needs to be across the spectrum for our patient population. Designing the program, our main objectives was improvement of clinical outcomes. Our focus for this project is health and wellness, because these were level 1, first year medical students, second year medical students, it's first year PA students, and then with the nursing, our nursing for the second semester was nursing that were in their practicum. They were getting ready to graduate with their BSN, so they had already gone through all of the different areas, the infancy, pediatrics, and adult. So their skill sets were a little bit different as far as their assessment skills, their interviewing skills, whereas your first year medical students and your PAs, their skill sets with their knowledge was a little bit more, was a lot more in depth, but they had none of those skill sets like the nursing did. So it was a really good blend because they relied on each other for help during these clinics, and it was very obvious with this reflection how much they valued the help of that other profession being there. Established basic levels of the interprofessional core competencies. The first year we started with the lower level, the first semester, and the level 1s of the med students 1s with just the roles and responsibilities, the task, ethics. And then as we progressed to the second semester, it was higher. Okay, we're going to take all of those core competencies and how are we going to implement it at the clinical site to improve our patient outcomes? This is where they looked at evaluation, you know, how are we going to measure what we're doing as a team? Recruitment of student participation. Each discipline was responsible for recruiting their students and how they did it. And then, like I said before, we grouped the students according to their specific skills. Our first year students had lower level, had nursing students for the first semester, and then our second year students had the practicum students or the students that were getting ready to graduate, and then we kind of carried that on. But I think in the second semester we saw that the nursing, when they were getting ready to graduate, was a perfect skill set, even for those level 1 or those first year medical students. So project outcomes, like she was talking with Cotter and Rogers, cultivating the need for change. We had to have, buy-in. We had to, it was a national urgency. It's all in the literature. They came out with the core competencies. So our culture of change was there because it's nationally, it's out there. We need to be interdisciplinary. Establishment of interprofessional teams. What we did is we had the 3 different teams, and when we chose the team members, we wanted to get those change agents. We wanted to get those that were going to go out there and really talk about this project and help with that buy-in. Professional development and establishment of vision. We established a vision that was congruent with all of our professions that came in. We sat down as a group and we talked about it. What's the vision of each one of the disciplines? Now let's get together and do a vision that will capture all of that. We did go to an IPAC conference. We sent 3 different teams. The first team, which had a representative of all the disciplines, we had a clinical component where we went out and we wrote collectively as a team what we needed out of that clinical experience for our students. And then we sent the curriculum team, and next we will send in October a refinement team that will go in and refine what we have produced. Transparent communication for buy-in is so important when you make a change like this. And what we found was a lot of people would talk the talk but wouldn't walk the walk. And so what we did was, we wanted that buy-in. We opened up invitations for other people to become involved. With this semester now, we have PT that's going to come in and be involved with me at Cathedral Place, which will be a wonderful addition to my team. But we wanted that buy-in. We wanted to say, hey, this is a great thing. Our biggest advocate for this, and the one who has sold this project the most, has been our students. This year, we barely even within, when we put out the call for the medical students, within, 1 minute or 5 minutes, we already had half of the medical students that we need, because our students see how valuable this is on what we're doing. Inspiring action, when we'd go to these, when we would talk about it in our meetings, which we had our meetings every other month, our team would get together. We had a working team, and then we had an advisory team. When we had these teams, we would all talk at the table, but then again, we'd go back into our own little silos and, do what we needed to do to get our goals accomplished. Once we went to that IPAC meeting and we had all the teams sitting at the table, that was a time for us to really discuss and to really, I think that's where we had a real turning point. Everybody got real excited about it, the team members, and really started to do that give and take as far as scheduling, getting students, that really buy-in. Recognizing accomplishments, this was just, it just was overwhelming what the end of this second semester has been. So what we did is we did an interprofessional student fellowship banquet that we gave to all of our students, and we called them our fellows, and so we recognized them, and we had a panel that was up there of students about what they learned for each one of the core competencies. So enlightening, and it was wonderful because we invited all of the administration to that really, I think just hearing our students sold it. And then continuing the movement, and then making it stick is what we're going to use from, we're going to continue on in our second and third year.
Okay, so I'll just go through these really quick. Obviously, the need for administration buy-in and resources is really critical. So we had department chairs, deans saying, we want to come into the project, but we can't give you any faculty. we want to give you our students, but we only have 2 faculty on the project, so bringing in 50 students is unrealistic to actually do what we're trying to do in these groups. So they're working this year on getting us more resources to support the growing project. Flexibility, compromise, and creativity, I can't tell you how tough that was. Those medical people come in, they know exactly what they want. Those nursing people come in and they've got certain guidelines. So being creative about your schedule, how you can accomplish goals, also being flexible is key. And please, certainly when you start doing this, give yourself about 2 weeks to plan meetings, because with everybody's schedules, it was very, very difficult, but it was very important to have everybody at the table. So if we had PA missing, we could not have that meeting. So we had to make sure that everybody was there, and that took quite a bit of time. And then professional development for training for faculty and students. That first semester, we just did an online orientation, and our faculty who were in those clinical sites spent a lot of time because the students had a lot of questions. So it wasn't enough. So this fall semester, we have a 4-hour session. All the students will be there, and we're going to be doing a lot more training up front, so that way we can resolve some of those issues. And then need for patient outcome data. Obviously this is huge. That's what we're starting to do this year. We kind of refine those instruments in the spring, so we'll be measuring that this year. Literature surrounding effectiveness of community-based care, there's not a lot of it. So we want to show that we are making a difference. Determining the impact of didactic curriculum on application of competencies. Again, we're teaching them these things, but how are they applying it now? Where's that transfer? So we as a faculty are kind of looking at that as far as our research. And then the effectiveness of training on postgraduate practice. So we are going to be following all these students when they get into their clinical sites with their preceptors, as well as after they graduate. Anybody have any questions?